is Dr. Mohammed Saleh. I'm a clinical assistant professor at the University of Michigan School of Dentistry in the Department of Periodontics and Oral Medicine. I practice in Birmingham, Michigan, and I'm honored to be one of the MISH educators. And I'm going to be discussing today with you the topic of simultaneous versus staged GBR. The idea is not new. It's a decision that we do every day. Decision is basically if we're doing a bone grafting or implant placement, should we do it at the same time, or should we place the implant at the same time of the grafting, or should we do that in a staged fashion, basically grafting and then coming back later after the bone is solidified and place an implant later. Before we discuss that, we need to know what type of defect we're dealing with. And the idea is to understand the nature of the defect, because after that, it's going to be easier for us to make this decision that we should be making every day. And the classifications have been introduced since 1988 by Cowell and Hall, and this classification is mainly quantitative, can be applied today and for overdenture cases, for example, but it's other than that is not super useful anymore. Again, it's only a quantitative classification. It tells us how much bone is lost, but with the evolution of implant systems and using short implants and evolution of grafting procedure and the way that we are placing implants today, it's and everything has changed. So this is not the most useful if we're making a decision to place an implant simultaneous or staged. Another classification which is still used is by the type of bony defect, by definition of the bony defect. So the bony defect can be called a contour defect, which is basically no defect there. It's just there is a contour deficiency that we want to graft to improve the volume. Do this typically in aesthetic cases. Maybe we do it as well to improve the thickness of the buccal bone, since this is important for marginal bone stability. But the reality of the matter and contour defects, we don't have a real defect. We're just adding bone extra. And this is the for extra security, but this is the easiest defect to deal with. Second easiest is an intra-alveolar defect, which is a defect around the implant, but it's fully contained. And this type of defect will typically be in immediate implant placement. We'll see it when we're doing immediate implant placement, or if we're treating some of the contained peri-implantitis cases in a regenerative treatment, of course. The third and the second and the being more challenging is the fenestration defect. This is a bony deficiency, window shaped defect that does not involve the crest of the ridge. It doesn't involve the platform of the implant, and that's definitely much easier to handle and less critical than a dehiscence defect, which is also a window shaped defect that is involving the crest of the ridge. Crest of the ridge is our main aim at any regeneration procedure, is to ensure that we have a couple of millimeters buccal to the implant, so that we have stable marginal bone that will support our tissue and will ensure some good implant health long term. Of course, this is slightly debatable how much bone we want and how much tissue we want, but we for sure know that if we have less than 1.5 millimeter of buccal bone, we are more prone to have some more marginal bone changes at the crest of the ridge. Another type of classification that is available is by the defect anatomy. Not the previous one was by definition. This is by defect anatomy. And actually, we can apply that to a classification that was not introduced for peri-implant bone regeneration. It was actually introduced for periodontal regeneration by Goldman in '58. And this is by the number of bony walls missing. But this, we can redefine it for implants, but this is us doing that. Goldman didn't introduce that, of course. And the classification is simple. It's regarding how many bony walls are left. So if we have 4 walls left, which was the intra-alveolar defect in the previous classification. That will be called 4-wall intrabony defect. If we have 3 walls left, that will be 3-wall intrabony defect. 2 walls left, 2-wall intrabony defect, and 1 left. That's a 1-wall intrabony defect. And classification is very intuitive. It's very easy to use. We use it in periodontal defect. It doesn't mean that we can't use it in implant defect, but it was not, again, designed for implant. One other classification, though, that was designed for implant defects, it's much more detailed, and it's actually more useful for communication when we're trying to decide if this is a defect that we can do or regenerate in a simultaneous fashion or in a staged fashion, is the CCAR defect, or the colon classification of alveolar ridge defects. So this has 3 parts. So we have to come up with 3 pieces of information to get a classification for CCAR. One is the orientation of the defect. Is it a horizontal defect, a vertical defect, or a combination of both, or a combination that is involving a sinus area? And part 2, is it how much deficiency is there? Is the amount of the reconstruction needed low, which is less than 4 millimeter, or medium, which is 4 to 8, or high, more than 8? And you can imagine a defect that is like a small defect, less than 4 millimeter, simultaneous will be very doable. And if we have a medium defect, maybe, but big chances we can do simultaneous. And if we have a high defect, chances are we can't. We need to do staged. And one of the most important aspects of this definition, which we're going to spend some time with later, is the relation to the ridge contour. Is it inside the skeletal contour, or it's outside the ridge contour? The skeletal envelope, or the bony envelope, or the ridge contour is a different names for the same thing, which is how contained the defect is. Again, we're going to touch on that later, but remember this is very important, because this is one of the main factors based on which you'll decide if you can place the implant simultaneously or stage, or is it knowing horizontal or vertical or big or small is useful. But the really thing that like points you toward the decision is the relation to the ridge contour. Other classifications that came later said, okay, this is all very good, but I want to know what to do. Basically, you're telling me I can do it simultaneous or stage, but does it need titanium mesh? Can I do it with just a collagen membrane? I want to know what to use and which type of defect. And one of the first classifications that tackled that was actually done by Homely Wang from University of Michigan, like more than 23 years ago. And that was the HVAC classification, which was the horizontal, vertical, and combined ridge deficiency classification. And basically, you have the same from the C-card and even the CBERT tissue deficiency classification before. We have horizontal defect, vertical defect, and combined, but each of them can be small or medium or large, as you can see. And the small, they gave a couple of options how to fix it, and the medium as well, and the large as well. And the good thing is they're not limiting you. And if you're like to do block graft or something, they're not telling you cannot do it, and small defect you can. It's just an overkill. But they're giving you all the options in each type of deficiency. And that was very useful at the time, and still very useful until now. Another take on that classification was done twice, actually, by a team from UAB, and later, 1 year later, by a team from Michigan and UAB, which went slightly deeper because they involved the GBR as one type of treatment and titanium mesh as another type of treatment. And then they even used, or they even gave some recommendations in terms of if you're using biologics or not. Should you use autograft or bone substitute or a combination of both. So they went deeper into the recommendation, and that was like very useful at the time because we remember like 2, 3 years ago, we started getting more like revival of some techniques like titanium mesh by using customized titanium mesh and similar scaffolds. So it was very timely, but it's not really much different than HVAC classification by Homely one. And I don't want to spend so much time, but the classifications, we have more than 40 classifications, unfortunately. It's a good thing to have all these classifications, but we want to like stick to one. And I'm going to introduce only one based on the skeletal envelope that we spoke about, because there is more into that. It's we can't just decide the classification based on the bony deficiency. We need other information. But before that, I'm going to speak slightly about the skeletal envelope. The skeletal envelope is basically the shape of the defect, the anatomic structure of the ridge or the defect. And the idea basically that if you have a defect that is contained, like this can be considered a three-wall defect, and the bony envelope, the three-wall defect is not getting much blood supply from the flap. It's getting mainly blood, or might be getting blood supply, but no cell migration or osteoblastic cell migration from the flap, but mainly from the bony cells. And this was demonstrated very well by the Boozer and Schenk study in '95. This is a landmark study, and all similar studies found the same thing. This is not a new info, but the idea is not how GBR works or where we're getting the blood from. The idea is to imagine this whenever you're doing guided bone regeneration, is to imagine the skeletal envelope, and based on that, you decide, how much bone regeneration should I expect? If I have like on the very left, a very contained defect totally inside the bony envelope, we have total containment of the graft in this skeletal envelope, I should expect very high regeneration capacity. If I have something that is outside the bony envelope, like the far right, we know that these implants are not getting any blood supply except from the basal bone, the lingual bone in this case. So it's very tough to place an implant and expect bone regeneration until the arrow there, the peak of the bone. So these are cases that you shouldn't be thinking of doing implants simultaneously. Can it be done? Yes, and we'll show you some cases, but this is not the typical recommendation because it needs to be done very carefully and with select types of GBR. Not any GBR will work. And there are borderline cases that might work, and this is based on also what you're using and your clinical experience in handling these cases, and we're going to also touch on that later. So bottom line, the healing in these cases, even though it's contained, you'll have some soft tissue and growth wherever you didn't have a bony wall there. And if we are placing an implant here, you should expect some deficiency facially because it didn't have a contained site. Again, this is how the basic biology of healing works. And this is how it looks before healing. This is what you should expect will look after the healing. And this is exactly why when we are doing vertical augmentation, you can see on the right, we're not expecting that everything we graft will turn into vital bone. We're expecting that always the final bone volume will be slightly less than the initial augmentation. With few exceptions we can speak about, but maybe in a different context and a different presentation. Now, the final classification that I'm going to introduce is classification that is not only giving you the type of defect, or more advanced, giving you the type and the recommendation regarding what type of therapy you should be using. It's also based on the prosthetic, ideal prosthetic placement of the implant. And I'll explain this in a minute. This classification that I'm going to explain and focus on for the rest of the presentation is the Bannock 2014 classification. It has 6 classes from 0 to 5. And this classification is, I'm not going to say unique, but it's like very useful to use day by day because it has the 3 components that we want. One, it has it's a prosthetic oriented classification, which basically is telling you will place the implant after you place the implant in the ideal position, 3D position, uh, how much of the efficiency there is. Why is this very important? Because you can always place the implant slightly deeper. You can always place a slightly narrower implant. But we're speaking about case that you want to place an ideal size implant, and then you're going to end up with a deficiency. So if that is not placed into consideration, we should consider other solutions other than grafting. Grafting is not always a solution. We can place narrow diameter implants in certain regions of the mouth. We can place shorter implants with more predictability, of course. 6 millimeter or sometimes shorter in the mandible and maxilla 6 to 8 are very predictable. So you can always go for a shorter implant and call today. Sometimes you can do a tissue graft to augment the volume instead of bone graft. But we're planning prosthetically and placing the implant in an ideal position, and then you have a defect based on that. Second thing is it's providing a choice of augmentation strategies, giving you a treatment recommendation. Not only that you're going to have a deficiency or not, after you have a deficiency, they recommend a treatment strategy. And after that, it's also recommending should you do it simultaneous or staged. So it's giving you the three most important things that you need with any classification. It's not too complex to do. It's very actually easy to understand. And we're going to spend our time, most of the presentation, presenting cases and applying this classification too. So we're going to go class by class. So class 0 defect, for example, it's exactly how it sounds. There is no defect in these cases. This is another classification. It was called contour defect. You have slightly contour deficiency. Actually, it's here between both implants rather than at the implant itself. But it's in the aesthetic zone. This is a canine or first premolar. So we want to make sure that we have, or a second premolar rather, and we want to make sure that we have a good contour there in a highly aesthetic case. So we add some bone, facially, collagen membrane, and then sutures, and this heals pretty predictably. Bennett class 1, it's a fully contained defect. It's a defect in an extraction socket, and we can see that Bennett in both 0 and 1 recommended simultaneous placement. If we go back, we'll see that what was recommended is simultaneous in both these cases, which is the 0 and 1. 1 has no defect, 0 has no defect, and 1, the defect is fully contained. In this case, we placed the implant and we placed a cellular dermal matrix membrane, the cellular dermal matrix in a thinner form, which is intended to be used as a membrane, and we gain some tissue thickness and the volume as well. And then we have Bennett class 2 and 3. So Bennett class 2 and 3 means that in 2, we have a peri-implant dehiscence that is within the bony envelope. We discussed already and explained what is the bony envelope. So we have a peri-implant dehiscence or fenestration. We discussed all of these terms earlier. That is within the bony envelope. And 3, we have one that is it is not totally within the bony envelope. It's a slightly borderline. And in these cases, he's saying that in stage 2 and class 2, he's saying you can do implants simultaneous with GBR, but in stage 3, he left it open up to your clinical experience. And this is a very important aspect, and we'll also speak about that later, that this has to be considered when you're picking what type of procedure you're doing, and if you're doing simultaneous or staged. This cannot be ignored. The amount of experience that you have dictates what you can do, and it also dictates what type of augmentation you should be doing. And it's not because so-and-so recommended this in a webinar or classification and saying it works that you have to do it the second day. You can take it step by step, learn, and then implement it in your practice. You don't need to do exactly the ideal treatment. You do the ideal treatment for you and your patient, not necessarily the ideal per se. Okay, so again, Bennett class 2 is a peri-implant defect that is within the bony envelope. Number 3 is a peri-implant dehiscence that is outside the bony envelope. And in this one, they recommended GBR or PTFE, and they said you can do it in 1 or 2 stages. So a Bennett class 2, as you can see, it is might be a very mild defect like this. It's still within the bony envelope, and this is nothing that you should be talking about. It's very easy. You should place the implant at the same time, and we expect like a very good regeneration from these deficiencies. This is very contained, or it can be slightly bigger. It's still within the bony envelope, as you can see from the occlusal photo. Always the occlusal is very important in seeing what's going on. And here they place just 1,000 shavings. It's the need to use. You can use bone substitute if you want, but it was a very predictable situation. And even this is a Bennett defect. Why it looks like, if you see this, or this is very advanced, it should always look at the occlusal and see, is this defect contained? Do I have blood supply from everywhere? Do I have, if I place a membrane here, this is like almost an immediate implant with a missing buccal wall. So this is still not a very severe defect. It looks severe when you look at the previous photo, but in the reality, once you place the implant, or before even you place the implant, when you're planning with your CBCT, you can see that after you place the implant will be entirely within the bony housing. So it is nothing to be too worried about, and it's something that you should expect good healing with. And in this case, we did as well lasso or herb roast, whatever you call it, using these are Maxon sutures, and this is an allo cellular dermal matrix as well, GBR form. And we close, and this is our closure, and this is before, and this is after. Before we send the patient back to the pros to do the second stage. Okay, Bennett class 3 is a defect that is outside the bony housing, and in this situation, Bennett and his group, they said that it can be done either simultaneous or stage based on the type of technique that you're using. So I'm going to show you both. So here we had not an extreme, but slightly bigger deficiency, but we decided to do it simultaneously in this case, and by using a ridge split technique. So you can see that we had like maximum 3 millimeters of remaining bone, or maybe 4. So we split it by using piezo. We did grease stick fracture here and full split from both sides, and we were able to place a 4-1 implant there. And we didn't graft the adjacent sites and call it a day. But we have, as we said, we have a stage 4, which is a horizontal ridge deficiency that we don't recommend, or Bennett didn't recommend placing the implant. At the same time, he recommended a delayed approach. And also in class 5, it's a horizontal and vertical deficiency that are beyond the bony envelope. Both of them are beyond the bony envelope, but 4, it's only horizontal, and 5, it's horizontal and vertical. So I'll show you an example of 4 defect, which is a horizontal defect that is slightly outside the bony envelope. In this one, we also used the rib post technique, but plus tenting screw. So we had about 1 or 2 millimeters left. Did the decortication, as you can see facially, placed the tenting screw to the extent that we want the bone to grow to. And then we used a membrane, cross-linked membrane that stays for like 5 to 6 months in place, which is awesome. And we used PTFE sutures and went in 5 months and had quite some bone, placed the implant, and that's it. And then we have a vertical defect that is purely vertical. In these cases, we don't recommend doing the implant simultaneous. It's just staged in this case, and you have to use rigid scaffold in this case, which means you have to use something like a PTFE membrane, titanium mesh, so either customized already, or bony blocks or plates, something like that, that will maintain the space vertically. And his conclusion at the end of the classification was in 0 and 1, you can do simultaneous for sure. In 2 and 3, maybe you can do simultaneous based on your experience and based on what are you using. And in 4 and 5, you should be using delayed. And based on that, we also made our own recommendation in a different publication, saying that actually you can as well do simultaneous in all classes from 0 to 3 with proper technique selection. But also we mentioned that that's the original classification, simultaneous and maybe undelayed. But we said that you can only do simultaneous, or you might only do simultaneous for class 0 if you're only comfortable with that, and the techniques that you're using are mainly collagen membrane and bone substitute. So you can reserve the simultaneous to the defects that are not like really big defects. They are only contour augmentation, and you can do everything else delayed. Or you can do simultaneous for actually everything except for the vertical augmentation, which we still, regardless of how good your experience is, we don't think it's a good idea to place implants with severe vertical and horizontal defects in a simultaneous way. We always think delayed will be a better option in these cases. And we want to also hit again on the point of the technique that you're using, because if you're doing a ridge split or you're doing a PTFE, like their indication might be very different because depending on which technique you're using, the recommendation for simultaneous versus stage might be very different. And a technique like a ridge split, for example, the technique was almost done to be or designed to accommodate implants to be placed there. So you're splitting the ridge, you're creating a contained defect that in all the classifications that we mentioned are suggesting that you place the implant at the contained defects because it's very predictable. So as long as you have good buccal bone and remaining after you do the split, then it's a very good idea to place the implant at the same time that you're doing the split. And this is very different, for example, than doing like something similar to the ridge split, but in this case, instead of splitting the ridge, we use the portion that we split to split it further to two bony plates and use it for a query technique. So again, this technique is basically doing a ridge split, but separating the split itself, taking a rather bigger split and using and splitting it into two halves and using one to do some vertical augmentation and the other to do horizontal augmentation, or to do only horizontal augmentation, but in a box technique, buccal and occlusal to fix the box. And then in this technique, for example, it doesn't make much sense to place the implant simultaneously. You have screws everywhere. You expect some remodeling around these plates, so you're not 100% sure where the bone will end. So why would you place the implant in this environment? This is a technique that will give you a lot of bone and a lot of stability. Actually, after you remove, you're gonna find this area very stable. But placing the implant at the same time, it's not very useful. And it's making everything more complicated. So, and this was our recommendation in a publication that we did last year in Peri 2000, that we said we were asked to do a new classification for GBR, and we said there are so many classifications already. We don't think the community needs another classification, but we think they need to understand the concepts based on which we classify the defects. They need to understand that the size of the defect is one thing, but they need to know the defect morphology. Is it extraosseous or intraosseous, or within the bony envelope, or the bony contour, or the ridge contour, regardless what you name it, or extraosseous. And then based on that, we suggest a time. You can do whatever, but we just suggest the intraosseous, again, extraosseous with how much deficiency, and based on that we suggest stage or simultaneous, how much deficiency if it's extraosseous or intraosseous, and suggest stage. And we gave some recommendations that you can use for each of these techniques because what you use for a staged and a bigger deficiency and an extraosseous defect is very different than what you should use for a stage and intraosseous defect. And we also gave some special considerations. What type of space maintenance do you need, or biologic, when you go from very minor defects to more involved defects. And we call this more of a checklist rather than a classification, because again, we have plenty of classifications already. And we also mentioned some clinical implications regarding that. So how to export this to clinical practice. We mentioned plenty of classifications, show you some cases, but I want to go over like step by step so that you can basically reach a decision whenever you're looking at a case of yours on a CT or clinically. And we're going to use the same concepts that we spoke about before this. These are photos from the Schenk and Boozer study we spoke about. And when they created a defect without membrane versus a defect with membrane, we saw that after 2 months, we have some migration of bone from the surrounding walls. And when they waited more for 4 months, they found almost the entire defect is filled except for the area that didn't have a bony wall here. And we can export that with the concepts that we learned about in the previous slides to tooth bound areas. So if I have a tooth bound area like this, and I look at it, I should expect the same from the slides that we've seen a couple of slides ago from Schenk and Boozer. I should expect from the sides of the bony wall some migration of bone from here and here and here as well. There is no arrow here, but you should expect bone from here, and a slight dip from here. So if you're placing a bigger sized implant and this deficiency, you shouldn't expect that this will be filled with bone. You should expect that after you open, you're going to find a small deficiency here, or barely some bone that is covering the threads of the implant, but not the 2 millimeter bone that you should be looking for. So in these cases, either you place a smaller implant, for example, or you use a different type of augmentation. And we just showed you a case earlier, and that's exactly the healing that you should expect. Some dip here. So we got bone, and you can see we did some ossidification. So we got some bump of bone here, but we have a small dip. That is very clear. So you either place a smaller implant, narrower diameter implant, instead of a 4.8, you place a 4.1, and you have your implant protected with some bone. Or if you want to still insist on to place a bigger implant, you should use something rigid to fully protect this area and give the bone here more time to heal so that you have more bone facially. And this can be done with using a Curie plate, for example. You can use Curie plate that is from the patient, or allogenic plate like in this photo. And you can do it simultaneous because we don't need a lot of screws, just 2 will be more than enough. And you'll have 3-4 millimeters buccal bone, which will guarantee very good bone dimensional volume around the implant, and will guarantee that enough time for this to turn over to new bone. If you have a free and saddle scenario, for example, like here, when you see this on your CT, you should expect, okay, if I place the implant here, I'm going to have some bone formation from here, small pyramid forming here, a small one here, and I might get some bone on top of the implant. So it is doable to do a simultaneous if it's next to a tooth, right next to a tooth. But if you're placing another implant a bit further, you shouldn't expect bone to be forming all the way here, because here this is almost a vertical defect. Here this is slightly different. We have some bone from this wall and bone from this wall, so this can be considered a 2-wall defect. This is a classic 1-wall defect. So we shouldn't expect much bone to have to be built here on this implant. So here, simultaneous is doable. If you're placing 2, you should consider staged. to have enough bone formation. But if you say I have to do it staged, then in this case, as we mentioned in the case before, you can use something rigid that will hold the bone and give you more stability and give you more time for the bone cells to travel there and form new bone facial to the distal implant. And again, the solution will be bony plates. If you have, again, the implant is here outside the bony housing totally, and we can place bony plates that will support everything until you have full bone turnover on these exposed threads that are outside the bony housing. And the same in the vertical defects. And this is exactly why we said we are not usually recommending placing implants simultaneously with vertical deficiencies, regardless if it's next to the tooth or if it's away from it, because even if it's next to the tooth, we don't expect much regeneration until top. We need to almost always use something that is rigid. We can't do this with, even if you sink the implant slightly, you need to place something rigid. And this is why we do it in a staged fashion, because it is very unpredictable if you do it with simultaneous. We can do it with simultaneous though if it's a combination of a horizontal and vertical. So like in this case, it's not pure vertical defect, it's mainly horizontal. We have a very minor vertical defect. The vertical defect, we made sure in this case that we don't involve the implants, and so we place the implants. We have like a 5 millimeter vertical defect. It's not a huge defect. So we placed healing abutments in this case, as you can see in the next photo, to just make sure that we don't suffer when we go in for the second stage to fish for the implant head. And then we fill bone until the rim of the alloplate, and then we close everything up. So does that mean you're showing us cases that are all simultaneous? Does that mean that you're recommending simultaneous for everything? Absolutely not, because we see lots of these cases that are coming to us that are because people wanted to place implants simultaneously. They just go for whatever angulation that is available to get primary stability. So not definitely recommending simultaneous with everything. I'm just saying that in many cases we can do simultaneous with proper planning, but because it saves the patient a lot of time and morbidity, but it doesn't mean that it is doable in all cases. And our goal usually is to, of course, we need to get good primary stability because we don't want to lose the implant and the graft. And we want to make sure what technique we're using. Again, it's technique dependent. We need to imagine first or predict how much bone we're getting based on the bony envelope and based on the implant position that we're placing virtually in the virtual plan, digital plan, and then decide what type of protection do I want. Do I want something that is resorbable or not resorbable, rigid or flexible? And of course, the main aim is to not to get only the implant and bone, is to get to 2 millimeter of bone buccal to this implant. And we really just spoke about technique dependence. So if we're doing the Benec 0 to 2 simultaneous, we can do that with a resorbable membrane. If we want to do everything simultaneous, except again for the vertical augmentation, we must consider a non-resorbable membrane. So of course, you don't need to use that in a 0 or 1 defect, but you can, of course, use it in 2 or 3 or 4, and not 5, because we don't recommend vertical with simultaneous. So you can, and if you're doing these cases, for sure, go for non-resorbable membranes compared to resorbable membranes, or you can use titanium mesh or Courier plates. Other than that, you shouldn't be using collagen membrane for bigger defects. And again, use this as a checklist rather than a classification. Look at all the aspects, which defect size, the defect morphology, the timing, and base it on that. And take the technique that you're more comfortable with. If you learn a new technique, don't try it in a very critical unpredictable site. Try it in something that you expect to work very well. And this is, for example, a surgery that was done with simultaneous implant placement in a very contained defect. The defect was a small dehiscence, fenestration, I'm sorry. So that's not a defect that we should be worried about a lot. And this, I think, was done with collagen membrane. See, and we're doing here papilla sparing incisions using a 12D blade. Just making sure that we remove all the epithelium. And then we'll make vertical incisions on both sides, one tooth on each side. Just teasing the tissue a bit with the blade, making sure that we have a full full thickness mucoperiosteal flap. And that's a very important part, that you want to make sure that you don't mix a split with a full thickness flap, which is a very common mistake, which makes the flap opening, the releasing of the flap makes it very difficult if you have like different layers. If you're sure from the first incision that you are fully on bone, elevating the flap is very easy. And then once you go to the MGJ, you want to make sure also that you're using your equiperiosteal elevator to be always on bone, on sound bone, so that you don't leave a ton of tissue tags on the bone. It decreases the quality of the periosteum that is still in the flap, and it makes the grafting also not very ideal, because you're grafting on tissue rather on bone. So whatever you leave, and here I'm saying that, and I'm seeing, for example, small tissue tags there. So these must be removed before you graft. And you can see the deficiency that is there. So when we were planning this case, we were not expecting any occlusal dehiscence. We're expecting a very small fenestration. So, and here, as you can see, we're using a back action chisel to remove all the tissue that is left on the surface. You shouldn't leave any of that if you want predictable grafting. So remove all the tissue tags on the bone with whatever instrument you're more comfortable with. And then we're replacing guide. Think a fully guided case, and making sure that the guide seats very well, and place the guide, and we're drilling, and we're expecting in this area to have a very small deficiency. So this is a case that you can definitely do simultaneous. You don't need to re-graft for that. It's the entire implant will be inside the bony housing. You have an area that is you'll have very thin bone or slight fenestration. So this is nothing that you should be uh, uh, hesitant to do it simultaneously. Just this is a BioHorizons implant. We remove the implant, the guide, and place a cover screw. And after we do the cortication, you'll see how thin the bone is. The implant is shining through the this area. we always do decortication, and we do it around the implant surface, and you can see the implant is shining through this area. So this is a very predictable thing. You shouldn't be worried about anything when you're doing simultaneous here. Um, we place, this is a cancellous bone graft from By Horizons, and place also striate membrane. So we pre-trim the membrane. We place the tail lingually, and then we fix it with one tack from the lingual. We just hold the pin in place with a blade before we remove the tack holder, and then we place another two tacks buccally, one on mesial, one on distal. And we always want to make sure that the bone is contained inside the membrane. If there is bone that is floating around, just push it inside the membrane, so it's you're not losing the bone that you're grafting. Even after you tack, you can do that. And this is one tack on the distal. Again, we hold the pin in place so that it doesn't come out with the tack holder. And we notice some deficiency, or the membrane is not very taut, so we just pull the membrane out, or unfold the membrane, I'm sorry, and then push this bone inside, and then add another tack. And making sure that the suction doesn't pull the membrane. Okay, and that's the third pin, and then I think we found the second pin was loose. We removed it and we replaced it again. Okay, now everything is stable, as you can see, and we have more bone than we need. And then we'll start with the periosteal release. Of course, in this area, it's pretty easy to do. You don't have, I mean, you can do it at the mental nerve as well with a semilunar incision. We can discuss this in another setting. But the idea of the split is we do one split only, like one line connecting the mesial and the distal vertical incisions, and then we do some stretching with blunt instrument, not with a sharp instrument, and then we get all the release that we need only from that. It's super safe because it's mainly with a blunt instrument. We just do the periosteal, main periosteal incision with a blade, and then we use a blunt instrument for everything else. So it's usually very safe. And then we do the first suture is always a horizontal mattress suture, and then can do either slings on the adjacent teeth or interrupted. Slings are good because they let the flap hug the tooth as much as possible, so you don't end up with any recessions on the adjacent teeth. And I think this is what we're going to be doing here. And it's always good to sling around the natural papilla so that you get good support. Doesn't hurt the papilla at all. So you go in the papilla that is in the flap, and then under the contact, and then we go in the papilla around the adjacent tooth and just tie. It's very straightforward. This guarantees good coronal advancement of the flap. So we never end up with recession on the adjacent teeth. If anything, we can get some coverage if it needed some coverage. Okay, and that's plenty. And we're gonna show you some cases for uh, scenarios that we use either simultaneous or stage and the rationale in these cases. So we're starting with a case that have a mix of horizontal and vertical deficiency. So in this case, we had horizontal deficiency only on the front tooth and a vertical deficiency on the back tooth. So we decided, as we discussed, if the front is very minimal, you can see the very minimal deficiency here, and this is a dehiscence defect. It's very easy contained, so why not do it simultaneously? So we did place the implant here. On the posterior, we have quite some horizontal and vertical deficiency. So we did the cortication, we did the flap release. We have a good amount of release here. This is the lingual flap release. And then we decided, because this is a vertical defect that needs rigid containment, as we discussed, we placed a PTFE membrane with titanium reinforcement. And in this case, we only used bone substitute. We didn't use any autogenous because the patient didn't want any autogenous to be used. And the good thing, or I don't know if it's good, but it showed us in the result how each works, that we didn't place the titanium membrane on the, or the PTFE on the simultaneous implant. We let it be exposed because, as you know, there are some also risk for exposure for the titanium, so I didn't want any exposure to happen on the simultaneous implant. So I just placed the collagen membrane, throw it there, and I close the flap, and this is the healing at 2 weeks. Okay. And as you can see, we got a good volume of bone vertically, as you can see here, and horizontally, very good volume at the front and the back, but the shape of the bone is very different when we used titanium reinforced PTFE versus a collagen membrane, because the collagen is not space maintaining. Like the only space maintaining that you get is just by the bone substitute, but the flap keeps shrinking. So you always lose some bone at the crest, whatever technique you're using with collagen, except if you sink the implant a bit and keep this protected. The most amount of bone changes that happen, the dimensional changes that happen at the crest of the ridge, where the shrinkage of the flap happens most. When you're using something that doesn't give under the flap, you're always going to maintain whatever you build. And this is exactly what we've seen when we went clinically. We have bone facially to the implant. It's not bad at all. We got quite some bone here, but it's most of the bone is at 5 millimeters or something from the crest, not at the crest itself. While if we look at the back, at the posterior side, we have a very broad table of bone because the titanium didn't give in under the flap pressure. Place the implant and close. In other cases, for example, if you have a deficiency in the aesthetic zone, many cases this is a small vertical deficiency. Actually, it's not a big vertical deficiency, but to get the pillow here, uh, we need to graft all this vertically, or, and this is a very young patient, so we for me, I can't. This is a high risk case that I will go definitely for something that is not resorbable and something that will not cause any dehiscence or fenestration. So I went for the ramus and I did Puri here, and I built. There was some also perio deficiency these teeth, so I built bone using the pony plates, occlusal and buccal, and inside I filled it with shavings of autogenous bone and allograft, as you can see. This is the occlusal view. Then again, closure was the same technique that we showed you before. And occlusally, this is a continuous and interrupted elsewhere. And of course, we have some horizontal matrix, one here and one here. And actually, we had some, as you can see, bone defenestration at that at the second stage from the plate itself. But when we opened, the bone looked amazing. We have full integration of the plate facially and occlusally, and you can also see from the occlusal view, we didn't lose anything from the vertical or horizontal, even though we had a very small fenestration facially. And to close the fenestration facially, we did a palatal pedicle flap that we placed to increase the height of the bone here, the height of the tissue here, to form papilla under the pontic, because this will be one implant and a cantilever. And and this is because placing two implants in this location is very next to each other. It's not super ideal aesthetically. You can do it, but it's going to come with an aesthetic cost. So if you want ideal aesthetics, for me, placing a bigger implant in the central and doing a cantilever on the lateral will give you the best aesthetic results. And we use the pedicle flap to give us a ton of tissue here and also to close the small fenestration that we had on the top. And this is a case that we've seen earlier in the beginning of the presentation, when some clinicians want to place an implant simultaneously, regardless of the technique that they're using or the anatomy of the bone that's available. We end up with cases like this, and this is not like a standalone case. We see a lot of cases like this with exaggerated vertical and horizontal bone loss because of the mal-implant placement. And this case, when we opened, we had, as you can expect, a horizontal and vertical deficiency. We fixed that with an allo plate. And actually, this is a very old patient, and we didn't want to do any, she didn't want to do any autogenous. And we went with allo plates, and again, full bone substitute for the deficiency. And you can see how small the restorative space is. Of course, the prosthodontist is taking care of that. And then same thing, we did only bone substitute and pedicle flap to increase the tissue thickness on top. And then we placed the pedicle flap on the bone substitute. Closure, and this is the closure of the palate. And this is the patient at the second stage. And we had a very decent healing. Again, full integration of the buccal plate. It's usually very integrated. When we place a occlusal allo plate, in many cases we have to remove it. We don't want it to be around the implant, but we definitely can gain a lot of bone. This is at the baseline, and this is when we saw the patient. We have a very small dip here that handling it will not be an issue at all, as you can see. So we placed the implant. We did another pedicle flap. It's very easy to do, and it improves the tissue quality a lot. And we just shaved some of the bone that was here from the plate itself. We have a very big plate. We shaved some bone from the plate and then placed it here without adding any bone graft or anything. These are just shavings from the plate because the deficiency was very small facial to the implant. And then we cover everything with the palatal pedicle and again, close flap. In other cases that look much more benign, so this here, we don't have much vertical deficiency. I have a very slight horizontal deficiency, but unfortunately we take a CT and we plan the implant, and the implant will be entirely in the incisive canal. And this was a huge incisive canal, as you can see. So there was no way away from that. We needed to do an intervention that involves either lateralization or removal of the contents of the incisive canal. And we actually went to removal of the contents because this was a trauma case. You can see there is a fracture line here in the bone, and this tooth had also a fracture. So we ended up removing this tooth and cleaning the contents of the canal, and then grafting both. We're doing also here, as you can see, decortication of the ridge that had a tooth that was lost, to an occlusal view. We're grafting all the deficiency here in the incisive canal. We're going to graft the socket as well. and place a collagen membrane and fix everything with pins. This is the buccal view and the occlusal view. And then we close everything up in the same technique that we showed you before. This is the occlusal. And then this was the patient in 2 weeks after we remove the stitches. Everything is closed up. We just wait, and we have excess tissue. It's always easier to remove the tissue before than end up with a deficiency that you can't deal with. And when we open at 5 months, we have plenty of bone. All the bone is integrated. Remember, this was again all bone substitute, no allograft, no autogenous graft at all. We have plenty of bone, more than what we need. Can place the implants in ideal position, and since we're opening the flap in the palatal that is now thickened from all the grafting that we did, we can also do a pedicle graft from the palatal, but in this time, we're just folding it under the buccal flap to increase the buccal width, and we're gonna show you this in a minute. So these are replacing very decent sized implants, and then we take our pedicle, fold it buccally, and then we fill the gap that is there with a collar tape. And I don't suggest that you close this primary. Actually, if you leave a small gap, small, very controlled small gap, you're gonna have extra KT, and we're gonna see that's exactly what happened with the healing. We still have a ton of tissue, and now we have a lot of tissue at the crest. You just wait for a couple of months, and then you do a second stage with a stab incision, or you can do a punch if you want, but you don't need to do more than that. And you can see these are 6 millimeter healing abutments. We have a lot of tissue, and your papillae are already built. You just need to place temporary crowns and start shaping the zenith there. So, and this is what we did. We delivered temporary crowns, and we sent it back to the dentist. All you need to do is just keep building the zenith here to your preference, and the papilla is already built for you. You can even open the contact more to get more pointed papilla if you want. And you can see that we have symmetry with the other side as well. But finally, we showed you some cases that are, most of them, they are done staged to gain a lot of width, but you should balance. And in this last case, see what type of procedure you can do if you have an advanced defect, but you still have a chance to do a simultaneous grafting. Would you do it or not? In this case, it was a case of congenitally missing lateral incisors, but we're a bit lucky in this case. If you can notice the deficiency, you had 3 options in this case: either to place the implant angulated, and you're going to end up with a complication that, like we've shown before, but if you place it like here, you're just placing it where the bone is, and you're counting on doing an angled abutment. Or you place the implant in the ideal position, but you're going to end up with a big fenestration or dehiscence, depending on how the bone looks. In this case, it's going to be fenestration. Or you do it in between and still place angle abutment. And we did it exactly where it should be, ideally 3D. And we can always fix the fenestration. It is a very contained defect. As we mentioned before, fenestration is not something that you should be worried about. If you look at it, it's a 3-wall defect. And we also, when we opened the flap in this case, we saw that we have deficiencies at the bone around the teeth itself because of the way the teeth need to be angled with ortho. So, and all this needs to be fixed. So if you're seeing this, you should be thinking of fixing the bone around the teeth and around the implant as well. So as I said, we placed the implants in the ideal 3D position, which meant that we're going to have fenestration defects on both sides. But we are lucky to have all these exostoses here on the right and left that we shaved, and we made some bony plates from these exostoses without going to the ramus or the chin to get plates. We just used piezo, got shavings from these exostoses, and used a bone scraper to get some autogenous bone, and then placed a cross-link membrane This is a longer elastic membrane that stays in place for around 6 months, and fix it with some lasso sutures, and healing is phenomenal in 2 weeks only. And can appreciate in the CT in 5 months how much bone we have around the implant and occlusal to the implant, and also around the teeth, which is very important. Like, forget the implant, it's good that we have that, but these teeth, all of them, they had fenestrations when we were doing the grafting. Now we have good thickness of bone around all the teeth adjacent to the implant site, so you didn't only graft and fit an implant there in an ideal position, you improve the phenotype of the bone and the tissue around teeth. And this is the patient at 5 months. Now the patient placed peak abutments and then sent the patient back to the general dentist, and this is the hand photo that the general dentist sent us after 3 years. And you can see the pins, the tacks are still there. And this is the clinical photo after 3 years. And very good tissue stability. And with that, I'd like to thank you for your attention today. And it was a pleasure speaking to you and a pleasure being a part of the Niche team. Thank you.